So I'll be talking today about thinking about youth-centered digital suicide prevention interventions and the future that we want to see in this regard. So you've heard a little bit about me already from that great introduction. And so I am located at the University of Pittsburgh in the Department of Psychiatry. With Jamie Zelazny, we have the Suicide Prevention Among Adolescents Research Center, and that really focuses very squarely on opportunities for adolescent suicide prevention. Thinking concretely about social media, the positive ways that it exists in teens' lives, and also some of the challenges that come along with that, and how that can influence mental health. And really thinking about how we can leverage novel digital tools towards suicide prevention. I wanted to first position this talk in thinking about where we are in terms of technology and healthcare delivery, with there being a shift in that really hasn't been quite that long ago. If we think back even to times before COVID, and we were looking at mental health claims, it was about 2% of claims were from telemental health at that point, increasing to 54% during COVID, and really decreasing a bit, but sustaining at 43% after the pandemic. And that's dovetailing at the same time that we're seeing a lot of increasing popularity of mental health apps. So we've really seen this giant explosion of digital mental health within services, which is, I think, what draws a lot of us to have interest in this webinar and thinking about different intersections and how to support this work moving forward. And with this integration of technology into services, there's a lot of opportunities to improve access to care and address a lot of the barriers that we know exist, from travel to time, offering that 24/7 support, extending reach in the midst of a lot of challenges. And it also adds some complexities, things like lack of universal broadband, and having considerations around accessibility in some degrees, while also thinking about considerations toward things like data privacy and security. And in the age of AI, those kind of considerations have never been more current than what they are today, while also having a lot of opportunity in this space. So in terms of where we are today in terms of teens in tech, it's 95% of teens are on apps and websites, about half almost constantly, a similar rate of youth using social media and a third using it constantly. The rate of use of AI chatbots, for example, has gone up quite a bit. About 67% of teens are using it, about 30% daily. And a lot of teens are going to technology for their mental health. It's maybe half or so are going to apps and websites, a large proportion social media, and increasingly also AI chatbots as well, with varied experiences with that. And so in this kind of environment, when we're seeing all the shift toward technology, I wanted to position this in terms of thinking about where are we in terms of adolescents' mental health needs, and where are we in terms of mental health support. So at a surface level, some things that we see are, large headlines that it's about 1 in 5 teens has a mental health condition. It's similar rates of suicidal ideation within the past year. And also, it's about 1 in 5 teens are reporting having unmet mental health care needs. And if we look under the surface, there's a lot that's explaining some of these gaps here. There are provider shortages, really significant provider shortages. And if we think about this in the context of adolescent suicide prevention, so if we have provider shortages, what about the context of are there providers who are skilled in working with youth? And then are they skilled in working with youth who are at high levels of suicide risk? And that number drops further, really suggesting that this is a significant barrier. Similar in a related way, there's also long wait times that relates to that provider shortage issue that can result in a delay of care. There's a high cost of services. There's also these internal and interpersonal, in some cases, considerations. Stigma is huge and it's prevailing. And also, particularly within youth with suicidal thoughts and behavior, there can, and within teens more broadly, but specifically that group, there can be a preference towards self-reliance. I don't want to be a burden on other people. I want to try to take care of this on my own, which sometimes can be a barrier toward getting the help that they need. there are significant health disparities, both in terms of rates of suicidal thoughts and behavior, and in terms of rates of certain subpopulations of youth getting access to care that they need, with disparities in them having less rates than others. And I'll go into that a bit more later. And there's also significant gaps in youth receiving the full course of treatment. So even if they get into treatment, a lot of the work from CBITs and the scalable mental health has shown that youth on average are having about one treatment session. And so there's a lot that we have to work with, and there's some cross-cutting issues. There's significant barriers to specifically evidence-based care, with a lot of the care that happens in the community not necessarily being evidence-based, and also culturally responsive care that's responsive to those significant health disparities that we know exist and is providing the right type of care that is responsive to adolescents' needs and their culture. There are gaps in care when youth need support and also in the spaces where they are most comfortable. Thinking about, the times in which adolescents experiencing risk actually when they're in the therapy room, often not. It's within within the context and the ecosystems of their daily lives, and the spaces where they're comfortable receiving care could really vary.
Candice, I think we just lost your slides.
Oh, really?
Oh, nope. I accidentally clicked the button. I apologize. I see him just now. Thank you.
You're good. And our services right now are often not designed or evaluated for youth who are at most risk. A lot of times suicidal youth are left out of the development of interventions or in their testing. Which can be really difficult because at the end of the day, we need them included to understand if we're working for that high-risk population. And where digital mental health can fit in with all of this is it could really stand to improve access to care when and where support is most needed, which is looking at this larger image, a really critical feat if we're able to achieve that. The work that I do is really dedicated to research that takes hold of the opportunity to leverage technology to extend access to care for youth who are vulnerable to suicide and also from underserved communities. Thinking a bit more specifically about digital interventions for youth suicide prevention, there has been really incredible work done so far. Looking at systematic reviews and meta-analyses, we are seeing effects on really common and important suicide risk factors with small to moderate effect sizes. I'm mentioning a few of the ones that exist there, the Lifebuoy app, the Therapeutic Evaluation Cognition app, and also the Bright app, which was developed by Dr. Brandt and her team at the University of Pittsburgh, really meaningfully and head-on addressing these issues of suicidal behavior among youth. And there's still a lot of questions that exist. So there's potential here, but there's also these unanswered questions. So first, how do we engage young people, and particularly thinking about our youth who are most vulnerable in terms of suicide risk and vulnerable in terms of falling out of or not having access to care? How do we reach youth when they need support, and also the times in which they want support when they are receptive to that? And also, how do we practically implement interventions within systems that adolescents frequent? With this last one being a pervasive concern, I think a lot of us are trying to think about and trying to find ways to optimize. I don't have answers to all of these questions. I don't know that any of us do, and that's why we come to these talks to a certain degree to learn from each other. But I do have some considerations that I think could be that are meaningfully happening within our field that we could really focus on. The first is thinking about opportunities to respond in the moment. So we know that suicide risk is dynamic. It can rapidly fluctuate within hours down to minutes. And that's not always aligned with the timing of services and in terms of when they are delivered. So if we can use technology to really address these windows of heightened vulnerability when youth are experiencing elevated risk through timely response, it could have quite a lot of promise, especially when we're doing this in a way that really are aligned and positioned within ecosystems of adolescents' daily lives. One approach to this is thinking about just-in-time interventions or just-in-time adaptive interventions that have shown an effect, albeit a small one, on mental health outcomes, and within a meta-analysis that can have duration of up to 6 months. There's a lot of meaningful opportunities to think about ways to optimize GITs, thinking about what really are the ideal triggers for the phenomena that we are studying. How does that align with patient comfort? So if we're thinking about accessing data from medical records or social media, how does that really align with comfort, with data privacy issues? And also how can we access this and deliver responses to that in a way that has timing that's consistent with patients' interest in timing when they're receptive to receiving support. A second consideration is thinking about ways that we can really meet youth where they are. Thinking about where do youth spend a large proportion of their time? Increasingly, we hear about adolescents using social media for a large portion of their day. It's on average about 4.8 hours. Adolescents spend a lot of time at schools and in other places within their families and communities. And how can we really leverage these moments to incorporate technology as a low barrier entry point, not as a replacement to therapy or other aspects of care, but as a way to have that entry point that they can then have to step up to different levels of care from there as is needed. There was a recent scoping review that found when digital interventions are combined with either existing resources or embedded within structures of adolescents' daily lives, they're more likely to actually engage with those interventions. And as a lot of us know, engagement is a really critical consideration within digital intervention research that can meaningfully influence clinical outcomes. And this really speaks to the need to reduce friction in youth attaining support by meeting youth where they are within their daily lives and in spaces that they're comfortable receiving care. A third consideration is thinking about centering lived experience. So I mentioned before, and I wanted to highlight this again, that youth with suicide risk are often left out of research. There is, there's a ethics board considerations. You're going to have a harder time with your IRB protocol anytime you're saying, yes, we're including suicidal youth. You need an assessment and management protocol to address this. And I would argue that leaving, youth out of youth with suicide risk out of research is when we do that, we don't know if the interventions that we have in place are actually going to have an impact on this high-risk group. And it's such a transdiagnostic issue. If we're studying depression, if we're studying substance use, if we're studying eating disorders, it's so correlated with many different factors that whether we address it or not, that risk is probably there within some of our participants. So meaningfully including them does matter. There's been 2 meta-analyses now that have found no harm to young people in participating in suicide-related research, which really gives us some good information that we can pass along if we're talking about ethics boards and so forth, to give an idea that this is a really important thing for us to do. And including youth with lived experience as active partners is really important to successful adoption and implementation. And we know that those are factors that actually make a digital intervention successful. So it's important, but it's also just good science for us to do this. And fourth, and not at all least important, is really confronting health disparities. So we know that there are pervasive disparities in adolescents' access to mental health care and in terms of suicide risk. And I've highlighted a few there. This is by all means not an exhaustive list, but we know that our rural youth have significantly lower access to care, particularly specialty mental health care, which is really the kind of level of support that you need to treat youth with suicide risk. We see also lower rates of culturally responsive care among racial and ethnic minority adolescents, and affirming care also within LGBTQ youth. And as someone who focuses on suicide prevention, this is meaningful to me because these are all groups that we are meaningfully focused on because of their risk for suicide as well. And this really means that this focus on health disparities shouldn't be something that we put in a grant submission and maybe do a couple of focus groups and kind of move on, but having a consistent focus, having it a framework that's constantly at the top of our minds in thinking about how we're approaching that work through that lens. And this brings me to the future of digital mental health, pulling all of these themes together, responding in the moment, meeting youth where they are, centering lived experience, and confronting health disparities. And next, I'm going to walk you through some of the research that we have done in this area that pulls on these themes. So the different research projects that I'll mention today all really focus on the development and testing of one intervention, but they came from different funding sources and had different aims and focuses. So the first was an American Foundation for Suicide Prevention Early Career Researcher Award that was called the ACT study. Concurrently to receiving that award, I also received my K award from NIMH. And that also had support from the Your Mom Cares Foundation. That was called the I'm Here For You study. And lastly, we've done some work to start moving into schools from a pilot study that was funded by the Etude Center at the University of Pittsburgh. That's an NIMH P50 Center grant and also had support from the Pittsburgh Foundation. And this is the wonderful team behind the work that we are doing. Tina Goldstein is the primary mentor on my K Award. David Brent is a long-standing career and significant career mentor. Satish Iyengar and Dorothy Espalage are co-mentors on my K23 award. Munwo Deshudhuri and Cesar Escobar Vieira have also been involved with different aspects of the studies that I mentioned. Emma Wynn and Morgan Rose are really incredible staff members, have been influential to all of these projects and have been very significantly involved, as well as a wonderful team of other consultants, staff, and students. Some of them are here today, so I'll mention them. Jill Sullivan, Sierra Strickland, Brenna Pagliarolo, and Megan Whitcop. So this project and this work that I do really focuses on the intersection of online victimization and suicide risk among youth. And when I refer to online victimization, and sometimes it'll show as OV on the slides, I think of it as an encompassing term that's bringing together online bullying, harassment, and discrimination. It's something that is common and detrimental for teens. It's about 30% of teens are experiencing online victimization. This is within national surveys looking at this within the past month, and it's highest among underserved youth. And the groups who are potentially most impacted are LGBTQ plus youth and youth of color. It's about 2.7 million teens who are experiencing the intersection of online victimization and suicidal thoughts. And this is meaningful because it is considered a strong risk factor for suicide. Suicide is the second leading cause of death among youth. And it's about 1 in 10 middle and high school students who are bullied go on to attempt suicide. So for all of these reasons, we thought an intervention that could really meaningfully address the mental health consequences of online victimization could be really meaningful for suicide prevention. And that's what we went on to do. And this first happened through the AFSP study that I mentioned. So we did qualitative interviews with LGBTQ plus adolescents. This award was really focused on LGBTQ plus suicide prevention with parents of those youth and also school and mental health providers that worked a majority of their time or had a significant focus with LGBTQ plus youth. We then moved on to a co-design phase in which we developed an intervention that was called Flourish with LGBTQ youth, and then we ended in an open trial with 10 youth within this population who experienced online victimization and lifetime or recent suicidal thoughts and behaviors. With my K award that I received concurrently to the AFSP study, it had a very similar study design. We were focused here on underserved youth a bit more broadly, particularly LGBT youth, but also youth of color. So we did qualitative interviews, co-design, and this study ended in a randomized control trial. And throughout the development process for those two different grants, it was really mutually guided by some of the tenets that I mentioned before, centering lived experience and confronting health disparities. And you'll see that come out as I move through these slides. The approach that we took also draws upon participatory action research, which is the idea that we're bringing about meaningful change with people, not for them. And in this case, the meaningful change being a digital intervention. Human-centered design, so iteratively building an intervention together with youth. And within that, a really focus on methods of participatory co-design and implementation science. And for this, thinking of it as an intervention development projects, it's really been planning for implementation and having that focus in mind. And this is inspired by many people, including the Discover, Design, Build, Test model from the University of Washington Alacrity Center, which you'll see on the next slide in terms of that was the approach that we used. And I think something in addition to this that I've thought about is also this kind of rigorous safety management being integrated within all of these other approaches. So thinking of it as an iterative, participant-formed, and culturally responsive process. So at each step, from the point of planning to thinking of the intervention design, actually developing the technology, and then evaluating this kind of work in a trial, thinking about safety management all along the way, in a way that's actually responsive to adolescents' need for autonomy, their need to gain skills towards self-management while still needing the support from other trusted adults in their lives, and how to weave that into the work that we're doing. This work was also importantly guided by a youth advisory board. There were 10 members on our board, or are. They're on average 17 now. They were a little younger when we started. Some of them have been participating for over 2 years. It's a national board. We meet via Zoom from different parts of the US. It's explicitly a group of underserved youth, of LGBT youth, youth of color, and many of them have intersectional identities therein and have lived experience within our topics of study. So they've helped significantly with co-design and given really advice throughout the entire study. So these were youth that we really recruited from prior studies, screened and consented them. We did this approach toward listening sessions that we really wanted to understand and take a moment privately to understand their lived experience before we jumped into a group process, and also gave some time to say, what does participating in a group as a person that has these kind of mental health conditions or suicide risk mean? What feels safe to you? How do we support that? We reviewed mental health resources with them and also had licensed clinicians on every single call. We largely didn't need to use those as backups, but we had them available. And half the sessions focused on research and half on education. And there were things that were within our area of study, things like mental health, social media, and also research methods. But there's also just things that they wanted to know about, college and career opportunities, with a lot of them being, juniors and seniors in high school at that point. We really tried to make it a bi-directional learning experience and a good opportunity for mentorship for them too. And this is just to give a quick idea and plug, I guess, a little bit for youth advisory boards. This is something that they put together about what participating in a youth advisory board means to them, bringing the sense of belonging, appreciation, advocacy, being able to help others with the same issues that I've struggled with. Just really a beautiful thing watching that happen with them. A lot of them have entered fields in health sciences, research, et cetera, after participating in this, probably for many different reasons. But I like to think that we played a part in supporting them along that journey. Okay, so moving into what we did, we used the Discover, Design, Build, Test model as a framework for intervention development. It started with qualitative interviews in the discover phase with underserved youth, with various identities within that, their parents, and also school and mental health professionals. And the goal of this was really to understand what intervention targets they perceive to be most important and modifiable in moments right after online victimization. We then moved into the design and build phase. This was really a co-design phase. And because we had these two studies happening and also youth advisory board, we had a fairly large group. I think for co-design, it was 55 of them in total. And this really involved a lot of iterative feedback. They were there from initial conceptualization of what should this be at all to the point of reviewing the majority of the text that went into the intervention, visuals, et cetera. And then we moved into this test phase where we were testing the feasibility, acceptability, and also preliminary efficacy of Flourish. And we did that through the open trial in RCT. So the Discover phase really focused on the voices of teens, parents, and school mental health providers. So I'll share with you first a little bit about what we heard from teens, and I will do that. Let me know if this plays. If not, I can talk through it.
I thought she was my friend,
Is this
but
playing?
she ended up bullying me for 3 years.
Why does simply existing make me a target of hate?
It makes you hate things about you that you can't even control. Sometimes I felt like the only way to get it to stop would be if I just ended it all.
I want a safe space, somewhere that's for me, where I know I'm respected and wanted.
I want a place where I could go to for help instantly, to see if I need help figuring out what to do next.
I want to feel accepted,
Understood.
Validated.
I want to feel safe to be me.
So what you heard, those were voice actors that were bringing to light some of the quotes from our qualitative interviews that were talking about teens' experiences with online victimization and the kind of support that they really felt was missing and that they wanted to receive. They talked a lot about how these experiences, for a lot of them, were not mild. They were severe. It really impacted their mental health. Some of them talked about how it either contributed to suicidal thoughts in the moment or it accumulated with other life stressors over the course of time in a way that they felt contributed to that, and that they really wanted safe places, and and really thought that a technology-based intervention could be helpful. What we heard from parents, a theme there was, I feel like I'm running into a fire blind. I feel powerless. They would talk a lot about how how social media has grown so rapidly and is different from the environments from which they grew up in, that they didn't really know how to support their child at a vulnerable time, and they really wanted to know how to do that and to do that well. With mental health providers, they talked about how services in this area are a blank slate, really talking about interventions for evidence-based interventions for social media and mental health broadly, really wanting more for their toolbox to give youth the support they need. And within schools, they talked about how this issue really happens constantly. It was one of a few issues that were really top in mind in the school administrators that we talked to, in part because they heard about it so often, in part with all the anonymous reporting hotlines that have been put in place in recent years. They're getting many reports about online victimization, and they find them difficult to address in a lot of ways, acknowledging that sometimes this occurs outside of school or it doesn't pertain to school and they need to provide support, but they have to find a way that is aligned with what they're doing too. They recognize that many kids are suffering in silence. So the majority of the kids are not experiencing or not getting the support that they need. And that sometimes they were finding out years later that the students are sustaining abuse over the course of time. That was a quote from a school resource officer who was saying he saw kids further down the line and really wanting a focus on prevention before mental health outcomes really emerge. The other half of the discover phase was also thinking about what this intervention should look like. And across these different groups, they suggested a semi-automated text message intervention. Semi-automating meaning there's a lot of information like instructions on how to use coping skills, or some educational insights about social media. They felt reasonable to do in an automated fashion, but they really wanted also for this to be an intervention that connected back to people within youth support networks. So it needed to be kind of a digital intervention that also got youth off of their phones. And text messaging, because it's something that has wide accessibility, even off of a smartphone, which was important for that focus on underserved youth. They set priorities for Flourish's content and functioning. It was they wanted it to be a safe space that felt accepting and private. They wanted it to focus on coping skills that can be used in moments following online victimization, which is really consistent with the research that suggests that distress can spike after online victimization. They wanted educational resources to aid response to online victimization, meaning problem solving in the moment. After this happens, what do I do? Do I report it on social media? But what happens with that? Do I talk with a parent? But will they understand? Will they know what to do? Really problem solving what to do in that moment. And also incorporating strategies to increase social support and actually engage in help seeking outside of just this texting tool as well. So we moved into the design and build phase, which is the co-design phase at this point. I won't go through everything. We did a lot of different HCD activities, but one that I think was really successful that we did early on in groups was storyboarding. And so we really had youth map out, what do you think this intervention would look like from the start? And we had them think about, if you're ready to seek help, what would this look like? What if you're not? And gave them different scenarios within that. So within this one, this group said, I imagine you enter start into a phone number and it starts by asking what happened. So it's not just going into, let me try to solve this problem, but it's stepping back and trying to evaluate things a little bit first. And then it asks, what's your goal for reaching out? So giving teens some autonomy and saying, this is what I need right now was really important to them. And when would you like us to check back in with you? So they wanted some kind of longitudinal support. If there was a recommendation to go to a text or a hotline, for example, for crisis support, that it checked in the next day to say, how did that actually go? I won't go through all of this, but we really took these insights in thinking about what the intervention should look like. And this is what it looked like in the end. It is Flourish. It's a text messaging and web-based program designed to connect within services within schools and outpatient mental health care. It was built on a platform that is HIPAA compliant and designed with safety management protocols really baked in across the board. It starts off with this friendly character Sprout that's meant to be an uplifting character that you can see, especially in the midst of a lot of negative experiences. It starts by with a little pin code for security, with an uplifting comment, and then goes into a questionnaire to help evaluate online experiences. And from there, it directs to a main menu where you can really choose the kind of help that they want, either in the texting program or our accompanying website. And so the menu options you see there really align with our treatment targets. It's offering support and learning about how to get support from someone. So it's in that section addressing motivational barriers to help seeking. The next section is about coping activities. So there's a library of brief coping skills. A third that's really on that problem solving kind of topic. So there's a lot of educational insights within that about what to do in the moment. And this is the website. It really mirrors the content from the texting program in a web-based version. And you can see you can also just directly connect to what is the same thing as the texting program on the website as well, connecting via two-factor authentication via email. So we moved from there into usability testing. This was with 20 youth who had never seen the intervention before. We showed it to them, had them think aloud about their experiences, and then evaluated that first quantitatively. And so we used the system usability scale, which measures perceived usability. And the scores were consistently in the excellent range. You can kind of see that they were between 85 to 91. You can see that what that means on that image there. And we also asked for their qualitative feedback openly, and we heard that Flourish was seen to be positive, have a caring tone, to be easy to understand, well organized, and a content that was meaningful to youth, which we largely attribute to all the youth input throughout. We moved into the test phase, so this was the open trial. With LGBTQ youth, they were between ages 12 to 17 with recent online victimization and suicidal thoughts and behavior. They were asked to use Flourish for 4 weeks. We followed them for 12 weeks. And it was a small sample, 11 youth, on average about 15, predominantly female sex at birth and with varied identities, which you can see on the screen. In total, youth use Flourish about twice per week, which was within the target that we had set initially. They thought Flourish was helpful. They rated it as a 4 out of 5 on helpfulness scale, with 5 being most helpful. The perceived usability scores remain within that excellent range, and we were able to achieve our goals for retention, which was meeting or exceeding 80% across time points. This gives you a quick idea of what happened clinically in terms of the trial. Keep in mind, this is 11 youth. We're really trying to look at feasibility, but we did also want to see what happened in terms of suicidal ideation, which is what's presented on this slide here. You're seeing the percent of participants in the study who endorse suicidal ideation on the Columbia Suicide Severity Rating Scale across our 3 time points. So baseline, week 4, and week 12, with the different colors aligning with different levels of suicidal ideation. So across the board, we did notice there was a drop in suicidal ideation and a fairly sharp one from the baseline to the week 4 time point. We did see it increase a little bit in the week 12 time point, and that's something that we'll be interested to learn more about within our RCT. Similarly, we did not see an increase in terms of suicidal behaviors, and the other continuous measures that we had of suicidal ideation also showed non-significant trends toward decreasing, as well as psychological distress. So right now, we are wrapping up a randomized control trial on exactly this topic. So we will soon have hot off the press results, I am hoping. But for now, I can share a little bit about what this is. So the design for the RCT, we're testing Flourish combined with questionnaires of online experiences compared to just those questionnaires alone. And the questionnaire condition is delivered via texting and in the same platform. And it's all among adolescents with recent online victimization and suicide risk. Recruiting from social media, Pip+Me is a participant registry at the University of Pittsburgh and also clinical services within our hospital. Following them for 6 months, looking at feasibility as a primary outcome, but also looking at TRACA mechanisms and outcomes related to psychological distress and suicidal ideation. The progress is that we've now completed data collection about last week, and we had great retention. It's 95% or higher across time points with no adverse events attributable to the study. So more to come on that. Some takeaways within our research to date is that Flourish shows promise as an acceptable intervention, and I think that's largely thanks to all the feedback that we've received from youth families and providers. We do have ongoing and future work to shed light on Flourish's clinical effectiveness that we'll be excited to learn more about. And another next step that we are actively exploring is opportunities to integrate Flourish within some of these ecosystems of adolescents' daily lives, which, as I articulated earlier, I find very important. And in terms of the alignment with the future of digital mental health, I think it again really underscores the importance of including youth with lived experience, and particularly youth lived experience who are from underserved communities, as a way to really empower, and doing so in a way that really empowers them, and collaborative decision making is a win-win because it adds scientific rigor while mutually offering a voice for marginalized populations. So thinking also a bit more about this theme of meeting youth where they are, I wanted to mention the work that we're doing to move into schools. So we consistently heard from our pilot research that schools would be ideally positioned to address the intersection of bullying and suicide risk because they're already doing a lot of prevention work in this space, but don't currently have anything at the intersection of online victimization and suicide risk. And so we have a project to adapt Flourish for use within school systems. It's called the Flourish in School Study. So our goal is to really do adaptation and an open trial, and we've now completed the adaptation process with an advisory board of school personnel from diverse educational settings across Pennsylvania, meeting small schools, large schools, urban, rural, special education, general education, and so forth. They really validated the need for Flourish and the need to position it within schools, and also gave us a lot of information about how to adapt Flourish with a way that aligns with implementation considerations. A specific one within this space is workforce shortages. And it varied a lot, with some of them saying we attained a grant and we have school-based therapists for our students, and that's great. And others saying we have one school counselor for 250 kids, or in some cases 500 students, meaning that there's really limitations in what they can do above and beyond their everyday work. When we have an open trial so far in 2 schools that are underway, and we're working on an R01 application. And if you're curious about some of the adaptations that we did, so we revised our current onboarding process, which was 30 minutes with a clinician and doing a lot of work to personalize intervention, and to realizing that that is not going to be possible within schools. So we moved to a health coach model, which in honesty was really inspired by a lot of the work at CBITs. And it involves a lot of automation within the setup process, but also pairing that with a health coach to make sure that youth understand, but are also motivated to continue using Flourish over the course of time. We included staff training and also weekly communication on Flourish. And we try to do this in little bits. So we have these did you know emails that give little bits of educational information about what Flourish is and its resources over the course of time. So it's something that they can consistently think about and learn about. And lastly, I wanted to mention some of the work that we've done in thinking about responding in the moment. So we were really aiming to respond to online victimization, distress around online victimization in the moment. And I'm mentioning this as a tale of iteration and flexibility, which you'll see coming out in some of the slides. So we set a goal of wanting to respond to distress experience around times of online victimization in the moment, and attain feedback through some of those qualitative and co-design work that I mentioned previously on a couple of options. This was an exploratory aim within my K to try to learn, is this feasible? Is this something that we can reasonably do? And so we asked teens their perspectives on a questionnaire. So this is something I modified from a prior ecological momentary assessment measure that I developed that essentially asks, think about times you've used social media recently. What was your experience, whether it is good, bad, or other? And how does that impact your distress level on a 1 to 10 distress thermometer? And the other option that we provided was thinking, what if we can actually detect risk from social media data itself? With the state of where what social media platforms allow, a lot of times it's hard for us as researchers to get access to social media data in real time. But there are some commercial companies out there, places like to give some examples, that GoGuardian or Bark, that have access to either school devices or adolescents' personal devices with consent from schools or parents to detect these kind of incidents of risk. So an example is that a parent would see this, for example, of there was a cyberbullying alert yesterday when Emily was on talking with Sophia on Instagram. Sophia says, "Stop talking to us, you're lame." Emily says, "I thought we were friends." And Sophia responds, "Everyone really hates you because you're annoying." So this might be what a parent would receive. And we had the thought, what if this is a trigger for response from Flourish? So first, the questionnaires were largely thought to be acceptable. We did a mixed method study leading into this that were with suicidal youth with history of suicidal thoughts and behavior. And in part because of that, in the interviews that we did with teens, parents, providers, they all thought that it was something that, as it existed, had fairly minimal burden. It was really something that they recommended, something that was ultra brief, and gave us some further suggestions for how to trim it down further. And teens really voiced that they appreciated this as a tool for strengthening self-awareness of their social media use, and also just positioning it as a tool that would support them in self-managing their mental health, which they really wanted to do. So you could see in some of the slides from earlier, we did retain the questionnaire and subsequently optimized it within our co-design phase. So in our trials, teens were using the questionnaire on average about once per week. And they did give us feedback during our exit interviews that answering these questions did help to increase their awareness of their social media use. So the other idea that we had was a bit more complicated. And this is some work that Sierra Strickland has done on this topic. And so in the interviews that we did with teens, parents, and providers, there was a lot of wide variability on the acceptability of this kind of approach of using these commercially available social media monitoring platforms. There were concerns toward false positives and fairly big red flag level concerns about privacy, particularly voiced among our LGBTQ plus youth, who had a lot of concern about their identity being outed. We then did a survey to try to get a more generalizable understanding of the perspectives related to this. So we did with 757 youth. It was a national survey on social media with youth with past year online victimization experiences. And though we didn't recruit them on the basis of having suicide risk, they did 59% of them endorse past year suicidal ideation. So it was a fairly high risk sample. And there were definite differences within these subgroups. So there were some groups who had lower rates of comfort with parents seeing their social media data, seeing alerts from them. Those were older adolescents, females, and LGBTQ youth. And there were somewhat higher rates of comfort among Black youth on those same topics. Although the overall comfort was still low, it was about 3 on a 1 to 10 scale of comfort, with 1 equal not at all comfort and 10 equaling extremely comfort. So with this variability and acceptance, we did not proceed with this approach. But we did iterate. We went with an alternative approach to thinking about social media detection. And that was with our collaborator, Dr. Mumu Deshudhuri. So we really moved from this commercial approach to a more research-backed social media-based algorithm approach, and really pivoted also to detection of online social support rather than online victimization. So Dr. Deshudhuri already had a deep learning and BERT model that she had developed with some prior students, and with some support from Active Raj and others on her team, we also later created a large language model-based classifier. This was no longer, to say this quite in the moment response, and I'll show you why in a second, but it was more thought to be a means to aid reflection on an important protective factor. So the process was the teens requested their social media archives. With the way that this works from platforms now, it can take about up to 2 weeks to receive them, which is why this by design couldn't be an in-the-moment response. And after the team at Georgia Tech would analyze these with the algorithms that they had, they would give us a series of, here's some snippets of text from adolescent social media data that was flagged as online social support, and give us back to us at Pitt. We did have a clinician in the loop reviewing everything. We were concerned that there could be misdetection, there could be some harmful things that social media that we didn't want teens to have to reflect on. So we had a clinician review and then present a report of the results back to teens. The response to this approach I think from parents and providers, they were skeptical just because there was more burden with this kind of approach. Teens were a bit more optimistic that it might be fit more realistically in their lives. Teens appreciated this as a data-driven means to reflect and find meaning from their online interactions and thought, reflecting on positive interactions might be helpful. It might bring back a sense of nostalgia. All the groups echo the need to find the right balance between privacy and safety. And so we did end up retaining the strategy, did a lot of work to optimize it within our co-design phase. In our trial, about 80% of youth did agree to provide their archives, and social support was detected then in 76% of those cases. Helpfulness was rated as moderate. It was about a 5.9 out of 10, with 10 being most helpful. So there's still room to further iterate on this. Some takeaways and future directions here. Again, this really echoed the need to get feedback from youth, and those support systems is really important to think about strategies that work in this space. And while these approaches show promise, we, despite our efforts, really had trouble finding something that would identify distress from online victimization in a way that was truly within the moment. So some of our next steps are exploring other options. For example, looking at real-time detection of distress from online victimization from passive sensing of smartphone data, and we have a grant under review within that topic. So again, checking back with the alignment with future digital mental health, this again highlights that offering support during heightened moments of risk is really essential, but how we get there is a bit complicated. It's complex. It requires iteration. It requires a lot of flexibility in terms of the evolving landscape of technology, and it requires, for all of these reasons, significant input from end users. So I'll tie this back finally to this sentiment that I mentioned at the beginning about the future of digital mental health. In bringing together all of these threads that I mentioned, the goal is really to build toward a future where young people, and especially those who are most at risk, can have access to timely, culturally responsive, and youth-informed digital support, ideally positioning it in the time and at the place where they most need the support and are comfortable receiving that. I'm really thinking about ways that we can build systems and recognize that no young person should have to face their hardest moment alone. So with that, I will end my slides, and if there are any questions, I'd be happy to take them.
Amazing. I think we're still, oh yeah, perfect. Amazing, amazing, amazing. I see someone has raised their hand. If you could add your, oh, they put it back down, but add your questions to the chat. Just what a beautiful program of work. You've done so much and just really impactful things. And also the graphics were so beautiful. So thank you for that incredible overview. We have several questions already in the chat. Folks may add more. I'll start with one that I love because it was a nice softball in a way. What software did you use for the bidirectional texting program?
Yeah, we use a platform. It's called SmartBot 360. So it's nice because it's something that you don't need a programmer to use it. So I have the person who's the coordinator for the study also built everything. They did have a little bit of past programming experience, but it's a really nice user-friendly platform to work with.
Awesome. Next question, and this is well, they fall nicely in order. So then the next question is, how did you recruit youth with lived experience when designing your studies? Was there anything you found particularly helpful when doing so?
Yeah, that's a great question. So when we are recruiting, it's in part been from past studies because we do a lot of work that is really focused on youth who have high levels of suicide risk. We're also positioned within a center there are clinical services directed by Dr. Tina Goldstein and David Brent that focus on treating youth with suicide risk, which provides we're really fortunate to have that kind of partnership that we can really work very closely with youth with lived experience. And in terms of what's been helpful for that, I think it's really centering their needs and their wants and recognizing, yes, they're not quite adults yet, but they're emerging toward that. And so respecting their autonomy, respecting their privacy as much as we possibly can, looking at them as experts of their own experience, and looking also for, especially within our advisory board, opportunities for mentorship. Like I think of that not just for the students that we work with who are coming in with research questions, but how do we extend that even a bit younger and to the people who are, the focus of what we're studying as well.
Really nice. A lovely related question was any tips or insights regarding your successful retention of participants?
Hire my research coordinator. No, I'm kidding. Um, um, I think a huge piece of it is consistency and flexibility. I mean, we sometimes have to reschedule appointments 4 and 5 times and umpteen reminders, and just allowing that to be the case. Paying attention to this person tends to respond on Fridays after 6 p.m. So that's when I'm going to reach out to them. We keep careful notes also about just things that are happening in their lives. The last time I talked with this person, they were going to be in their school musical, and check back in with them. Really make it so that there's this kind of we're offering this kind of communication and support to them over the course of time as well.
Love that. Question, first, thank you for your talk. Did I hear you correctly? Excuse me, that you used an LLM-based classifier to identify examples of online victimization content? And if so, how did the classifier perform in terms of accuracy, et cetera? And if it provided examples of problematic content, was there a risk of hallucinated examples when the LLM generated the report? Thank you.
Yeah, so it actually was used to identify experiences of online social support. At that point, because it was something that couldn't be provided in the moment with the way that the platforms allow us to have access to data, stepping away from looking at victimization content that may have happened 2 weeks ago versus reflecting a bit on potentially positive experiences felt more meaningful. The accuracy, I gave a talk about ADA about this. It was I think there's a lot of room for improvement within that, just to say. But I do feel like there were definitely a good number of youth who said it really did identify experiences in my life when people came to my aid or just were there when I was having a terrible day. And looking back to that did give me some reflection that there are, I have these negative experiences, but there are positive ones too. I think the complicated piece is that with anything with AI, it is not perfect. And so there were some cases in which it was bringing up things that our clinician was able to filter out and not show back to youth because it could have been, at least from our perspective, looked like it would have been harmful for them to see. And there were other times in which it maybe identified support accurately, but it was kind of a mixed experience. They were receiving support after a really negative emotional experience. So reflecting back on that was kind of a mixed experience. So there were a lot of complexities around all of this. And I think it just further circles back to that need to iterate and constantly be keeping up to date with things. I'm not sure that we've 100% solved it, but it was a really unique experience that I think helped us move forward to understanding what would work well within this space.
Thank you. And then a slightly different direction question. You mentioned doing work in schools and trying to scale out. And so one question, there's a very emotionally related opening conversation that this person put in their question. For the interest of time, I won't read that part. But essentially, they were talking about, is there a way to inject these positive resources onto these platforms? So instead of making things so medically focused, make it more generalized, that the positivity net can be cast far enough to reach more of our youth before they're, moving into dark holes of extremism. So wanted to get your thoughts on what it means to do partnerships with social media platforms and making them make positive resources accessible.
Yeah, I think I appreciate that there could be a lot of thought regarding that. And I'm picturing the person's comment that I can't quite see. There is such a huge need to create environments on social media where teens can get access to positive information, especially with just the way that things are structured, with the way that algorithms work in unfortunate ways. And I think there's when we're reporting things, is anything really happening to them? There is a lot of opportunity there, and I would love for there to be some collaboration with social media platforms to think about ways that we could directly connect youth, more specifically to suicide prevention. Not necessarily just resources. Connects into a crisis hotline is wonderful, but what are some brief technology-based interventions we can really provide in those moments? And there's such potential for scale and such potential for positivity within that. So I really appreciate the question and agree that it's a really important direction.
Amazing. I know we have 2 minutes till the top of the hour. I want to just say thank you so much for this beautiful talk and overview of your work. Congratulations again for the Rising Star Award. To the audience, tune in next this coming fall for our next series of the year. And just grateful for you all. Thank you so much, Candice, for this great talk. You're getting lots. I love all these emojis that come through. And I don't know if you could see them during the talk, but they were happening a lot as well, particularly when you showed your youth advisory board image. Really beautiful. Thank you all.
Thank you.